Hi, good morning and good afternoon, depending on where you're joining us from. My name is Jeanette Contreras with the National Consumers League. Thank you all for joining us today. NCL has been on the forefront of raising awareness of the outsized role that pharmacy benefit managers, or PBMs, play in the drug pricing process. Right now, the Federal Trade Commission is seeking public comment on how PBM practices impact access to medications and ultimately patient health outcomes. It is important that the FTC hear from patients who've been negatively impacted by PBM practices. So we thought to host today's discussion to highlight the key issues that patients and consumers should be aware of. Most of us are painfully aware of the high cost of prescription medications, but we don't fully understand why we pay what we pay at the pharmacy counter. Originally, PBMs came into existence to streamline how consumers get their medicines. They were intended to lower costs. But today, these major middleman corporations are taking advantage of the drug pricing system, hiding behind the scenes, limiting competition, and profiting significantly. Today, we'll hear from several experts about the many ways PBM practices impact consumers and patients, and how the FTC can help put a stop to how these unfair practices work. Before I introduce our speakers, I want to mention today's webinar is being recorded for future educational purposes, and it will be shared on our site, which is nclnet.org/PBMs. If you have a question for any of our speakers today, you can click on Q&A at the bottom of your screen and submit a question. So without further ado, I'll introduce our first speaker. Our first guest is David Balto, who previously served as the policy director at the FTC and currently works as an antitrust lawyer. Thank you, David, for joining us. David will give us an overview of the PBM issue and why the FTC took interest. We really appreciate your time today.
Thank you, Jeanette, and thank you especially for NCL's valuable work in paying attention to PBMs. The Justice Brandeis once said, sunlight is the best disinfectant, and this is an area where we need lots of sunlight. You know, I'm a former FTC antitrust enforcer, and we learn in FTC school there are three things you need for a market to work effectively. You need choice, you need transparency, so you know what the bargain is, and you need a lack of conflict of interest. And on all three counts, the PBMs receive failing marks. You have a lack of choice. 3 PBMs dominate the market with over an 80% market share. And the proof of the pudding is that we see their profits increasing from $10 billion to over $20 billion just in over the past 10 years, a period of time in which they allege there's robust competition. There's a lack of transparency. And we have to go no further than the fact that the PBMs used to gag pharmacists, prevent pharmacists from being able to tell you where the lowest cost drug was until Congress passed a law preventing those kind of gag clauses. PBMs know they make more money when consumers are unaware of what's going on, and that they battle against transparency whenever they can. And finally, conflicts of interest. We know there are conflicts of interest involving PBMs when they compel consumers, they force consumers from going from their pharmacy of choice, from using their drugs of choice, to going to the PBM's own pharmacy, especially their own specialty pharmacy. What's the result? Consumers have fewer choices of places to get their drugs. Consumers are paying more because PBMs have rebate schemes in which they get money from the drug manufacturers to favor certain drugs. And those rebate schemes are supposed to lower drug costs, but do they lower drug costs? No, they don't, because of that lack of transparency. And that's why we see the profits of the PBM skyrocketing. And consumers are being denied, not only paying more for drugs, but they're being denied those better drugs, the more efficacious drugs that can really preserve their health. This is a system in which we've unfortunately allowed the PBMs to take charge, and consumers and payors are losing in higher costs and less choice. Thank you.
Great. Thank you, David. We really appreciate your expertise here. And as I mentioned earlier, the FTC comment period is open until April 25th. And it's really important that they hear from all the stakeholders available to better understand this issue. So with us today to continue the conversation is NCL's very own Executive Director, Sally Greenberg. Sally, could you please share a bit more about how PBM practices impact consumers and what the average consumer can do about this issue?
Yes, and thank you so much, Jeanette, for hosting this discussion, and thank you, David, for being with us. I'm glad you mentioned Justice Brandeis because he was the general counsel for the National Consumers League for many years until he went on to the Supreme Court. So it's always a good name in the NCL space. Yes. So indeed, the fact that PBMs have the influence and decision-making authority that they do should be concerning, I think, for all consumers. PBMs have the power to negotiate discounts with drug manufacturers. They work with insurance companies to determine which drugs will be ultimately covered. And they work with pharmacies and pharmacists to reimburse them for dispensing drugs. But all along the way, they have found ways to profit. And all along the way, this impedes savings that should be going into the pockets of consumers. Take insulin, for example. A Senate Finance Committee report, bipartisan, found that savings to PBMs due to rebates are doing nothing to help consumers when it comes to the price of insulin. Another report showed that the net price on one insulin product and what the company earns as revenue declined by 53% since 2012, while the list price, what patients actually pay, increased by 141%. So patients who need these life-saving medications are losing out to PBMs, and this simply should not be happening. The FTC's comment period is a critical time to weigh in, and anyone can do so, and we encourage you to do so through the FTC website or by visiting ncl.org/PBMs. We provided a platform to help consumers better understand this issue and directly share their thoughts with the FTC. And I think any and all comments in this direction will be read and very much appreciated by the officials at the Federal Trade Commission. Thank you, Sally.
Yeah, this is really important. So we are going to hear from our next expert. This is a complicated issue for sure, and we are excited to have Carl Schmidt here, Executive Director of the HIV and Hepatitis Policy Institute, to share his perspective on the role PBMs play in driving up costs and the impact on patient access. So your voice is really critical here, Carl.
Thank you. Thank you, Jeanette, and thank you everyone for your interest in this issue. So if I could have my slides up. Thank you. I'm going to talk about, I represent the patient community. And so next slide, I'm going to talk about the impact of PBM practices on patients. You heard David and Sally talk about them already. I'll go in a little more detail. But first of all, the drugs have to get on a formulary. And this is the list of drugs that each plan insurer covers. I know a lot of people focus on insurance companies on these issues, and they may be, responsible for setting the premiums and the specific cost sharing, but it's really the PBMs that are making all these decisions for the insurers and the employers. So that's why, that's what I'm going to talk about, the role that they have. And first of all, in formulary decisions, they decide which drugs are covered. Yes, there's certain laws that you have to cover a number of drugs. You're supposed to go through a pharmaceutical and therapeutic committee to decide to make sure they meet clinical guidelines. And but then there's another layer, and you already heard about the role of rebates. So they decide based on not only clinical guidelines, but also how much money, how much rebates you're going to give me. And, we already heard about there's a oversized decision, concentration of just 3 PBMs. So they cover, when they're negotiating with a drug manufacturer, on the other side of the table, they have a lot of power and they're covering a lot of lives, and there's not many options for a drug company to go with. You basically have to go with them or your drug's not going to get covered because they cover so many people's lives. And so they decide basically which drugs get covered or not based on rebates. And if you give us a better rebate, we're going to cover your drug. If you don't give us a good rebate, we're not going to cover your drug. They also do that when a new drug gets approved by the FDA. Patients want those drugs immediately, but PBMs have a door, and they're the ones responsible for opening that door to patients. And so when a manufacturer comes to the PBM and says, we have a new drug, they say, well, you have to give us a higher rebate to get it added. And then PBMs, we also find, are removing drugs, even mid-year. And so this is really bad for patients. They have to switch their medications. That's not good for them. And, they're stable on a certain course of treatment. But this is what PBMs are doing. And then now, because of the power of these 3 large PBMs, we're seeing just drug exclusions and outright drug exclusions. So it used to be maybe 100 drugs a year by each of the large PBMs, but now it's between 400 and 500 drugs. Most of them, almost 500 drugs, they just exclude from drug formularies. So next slide. So that's what they're doing in just having the drugs on the formularies. But then when it comes to patient affordability, they're the ones who decide what tier a drug is on. And now we're seeing more and more tiers, maybe up to, it used to be maybe 3 or 4 tiers. Now we see so many plans with, 7 tiers. And a lot of that is based on rebates. The higher the tier, the higher the patient cost sharing. And then, it will probably, the patients want the cheapest option. Well, sometimes the cheaper option is, gets a list price of a drug is maybe on a higher tier if it's a lower price, but maybe the higher price drug, it could be lower. It all has to do with the amount of rebates. It really all doesn't make sense. And what we were now seeing is the creation of specialty drugs and specialty tier. It used to be, this is a term created totally by the PBMs. It was first for drugs that have a special handling, like injection drugs or refrigeration. And now it's just any new drug, all HIV drugs, all hepatitis drugs, all cancer drugs. They're all specialty drugs these days, and they put them on the highest tier. And this creates, it's higher cost for out-of-pocket costs for patients, but it's also discriminatory against people who based on their health condition. And that's one of the premises of the Affordable Care Act. You cannot discriminate based on people's health condition. And they've said, if you put every drug to treat a condition on the highest tier, that is discrimination. And the federal government has come out again and said that, reminded the plans that you cannot just base it on the cost of the drugs. You have to look at clinical guidelines as well. Well, I was watching some of the comments that came in from insurers and PBMs, and they disagree with that. They say, no, we should be able to put all these drugs on the highest tier. And then I think this is one of the most, incredulous things that they do is they charge, we have more and more people have high deductibles and co-insurance. We don't see co-insurance in many other health, you don't go to the emergency room and pay 50% of the service or the hospital. But you do see that for prescription drugs, 50% of the cost of the drug are in as you pay your deductible too. But PBMs are saying it's on the list price of the drug. It's not accounting for all the rebates, which is up to 50% on average of the price of the drug. And so patients who are generating those rebates don't benefit from those rebates. Now, it does lower the cost of premiums for everyone. And but, not everyone is using those drugs and generating those rebates for the PBMs. And so we feel that, this FTC should, be made aware of this issue. Next slide. Next slide. The other thing I wanted to touch on is something called copay accumulators. And it's only because of the integration of the insurance companies and the PBMs and the integration that they're owned by the same people. And they know what information patients are going through as they pick up their medications. What they've done is institute copay accumulators. And these are really damaging to patients who rely on patient assistance programs from drug companies. What they're saying is, oh, you could use those that drug copay assistance, but it won't count towards your deductible. So what ends up happening is people pick up their drugs, they think everything is fine and they're meeting their deductible. Then they find out it wasn't, and they're stuck with $1,000 or more bill. And who has that kind of money? But it's because of the PBMs, they're instituting these policies. Thank God, some states are stepping back and saying this, this is illegal. And, patient assistance has to count. But this is another thing that the FTC has to, be made aware of. Next slide. Just two more issues. They really decide access restrictions. Utilization management, such as step therapy and prior authorization. Again, not based on just, medical guidelines, but on rebates. So, they could say, we'll cover your drug, we'll put it on a certain tier, but if you give us more rebates, we're not going to put step therapy on it, a prior authorization, and vice versa. If you do give us a good rebate, you're not going to have, prior authorizations. Also, they decide pharmacy access, whether it's mail order, specialty, or retail. And, they require you, to go to a certain pharmacy or a certain mail order. I know a lot of our patients don't like to have their drugs delivered at their door, and they'd like to go to the pharmacy. But they say, oh, you could use, a retail pharmacy, but you're going to have to pay more. This is all being done with very little transparency, very little regulation. And as I said, as I showed you earlier, because of the high number of rebates, it really does contribute to the overall cost of drugs. Next slide. So it's really important that consumers and patients speak up and talk about your experiences and what you've heard, submit comments by the April 25th deadline to the FTC. This is the site where you can do it. And also the NCL has a patient portal, a consumer portal to submit comments as well. And I just encourage people to speak up and sign on to group letters as you see them as well past your desk. So really appreciate it and look forward to any discussion.
Thank you, Carl. This was really great to hear. I mean, I think we sort of get used to navigating all these things like step therapy and prior authorization, and we've just sort of, as consumers, go through trying to figure out how to work the system. And so, yeah, we definitely want to hear more about. We're gonna enter our discussion period, so we're gonna take a few questions, and I want to start with a question to David and. Talk a little bit more about, what the FTC wants to hear and what their role is. What can they do? Like, what's on the table? What more enforcement can the FTC do? What are they looking to do, when they get all this feedback from the stakeholders?
Right. So I want to start off with one proposition that I hope we will all walk away with. And it's going to sound so amazingly counterintuitive for you that you're going to have to hold on to your chair. We have to educate the FTC, the leading consumer protection agency, who the consumer is. Now, in matters like this, the FTC traditionally thinks the consumer is the first entity that pays the bill, that is the insurance company. So when there's a PBM merger or anti-competitive PBM practices, the FTC goes to the insurance company, which is large and has sophisticated negotiators, and asks them if it's a problem. And they can say, no, not really such a problem. We negotiated that. And they go, okay, that's fine. They forget there are real people like you, me, and Carl, and Jeanette, and everybody, all 90 of us, that are real consumers. So the most important thing we have to do, and the reason why these public comments in the work of NCL is so vital, is we have to educate the FTC who the real consumer is. Now, let me make this concrete. PBM enters into an agreement with an insurance company to force you, an HIV patient, to get your drugs through mail order. That's really a problem because there's a lot of counseling that an HIV consumer gets from his or her community pharmacy. And they may be doing monitoring of drugs and things like that. But instead, you're forced into mail order where you get to deal with any of 100 people on the other side of a 1-800 number that you may or may not be able to get through, and you're not going to deal with the same person all the time. And as Carl said, you're going to lose your privacy. People will see that HIV drugs are perhaps being delivered to you through the mail. There are all these adverse effects. And by the way, in California, that because of a case I and other people helped bring, that kind of conduct is not permissible. So the most important thing, and the insurance company liked that arrangement, they were paying less, but the consumers are totally worse off because the consumers are not getting the quality of care that they need and that they deserve. Now, what does the FTC want to know, and what can they possibly do with it? I think they want to know the kinds of practices, and I think individual complaints are very, very important. You may just say I'm one person, but the FTC can pull all these pieces together to see a course of conduct. The FTC has broad powers in doing a study, which is what they're considering. And we want to really flesh out the issues they should study and the kind of information that they can secure. The PBMs have been incredibly successful over the last generation in avoiding that kind of searching inquiry. And that's what's really necessary. Ultimately, the FTC has a broad range of powers to bring cases to stop anti-competitive conduct of PBMs or to enact regulations to stop practices that are deceptive or manipulative or otherwise abusive.
Awesome. Thank you, David. So we have a great question from Christine Zimmerman in the audience, and I think it's a good question for Carl to take. So who in Congress is willing to take on PBMs, and what legislative initiatives are out there?
Well, that's a good question. And, there's a lot of discussion about drug pricing in the country right now, right? Everyone's talking about, oh, I'm paying so much for my drugs. And, in Congress is responding, there's legislation going through the House and the Senate, and everyone says, we got to lower the price of drugs. We got to lower the price of the drugs. Unfortunately, the bills that are moving and aren't really going to, yes, in the Medicare space, there is a reduction of caps and things like that, which is great. But you're not seeing that in the private insurance market and up on the Hill. There's no discussion of that at all. As you and I, want to pay less for our drugs at the pharmacy counter. So I really think that they really got to, do something and examine the PBMs as part of this. And there's a couple of ways they can do it. One, transparency. No one, as I said, they're not regulated at the state level, much. They hide behind the insurance companies. They're the ones who get regulated. So we need increased in transparency. And so a reporting of rebates, I think, would be a good start. But secondly, I want to pay less for my drugs. And so I think that they really should base, the out-of-pocket cost, the deductible, the co-insurance on the net net price of the drug after rebates, and that the rebates should be factored out of how much I pay for my drug, because it's just not fair for patients to be paying on the list price. So I would hope that that's what the Congress and in the insulin, example that Sally brought up, I think is the perfect one. That you're seeing that the list price of the drugs are going down, but the rebates are going up and up. But people are still complaining about the high cost that they're paying. It's all because of the PBMs.
Thanks, Carl. And so you mentioned sort of what's going on in Congress, and we're going to look at what's going on in the states. So Sally, this question is for you. So are there any states looking into this issue or looking at solutions?
Well, yes, in fact, there are. And I have to quote once again Justice Brandeis, who famously said that states are the laboratories of democracy. And he was so right in the case of PBMs, because in fact, several states have identified policy solutions to redirect PBM savings with prescription drug manufacturers, to redirect those savings to taxpayers, patients, the public, and the private sector health plans. One of the most promising and successful of these solutions is the PBM reverse auction process, which helps create a more competitive marketplace where PBMs would compete with one another for any given state's business. And in fact, New Jersey, New Hampshire, Louisiana, Maryland, Minnesota, Colorado, and Ohio have all moved legislation in this direction. And in fact, just last year, West Virginia became the first state to pass legislation mandating that insurers and PBMs are required to pass negotiated discounts and rebates directly to consumers.
Yeah, thank you, Sally. We have definitely.
Can I add to this, Jeanette?
Absolutely.
Yeah, I love the passing on the savings to the patient, Sally, but there's some basic things that haven't happened in the states yet that I'm really excited to see. The transparent, first of all, being licensed. A lot of PBMs haven't been licensed in the past. And they haven't been regulated by the state insurance commissioners. More and more states are doing that now, requiring transparency, requiring a reporting of the rebates. And no one wants to see individual drugs, but to keep all this information confidential. And there's some of that happening at the federal level as well. But it's great to see this happening around the country.
Thank you, everyone. I guess I should give David the final word. Would you like to say one more thing as we wrap up?
No, I think it's just vital for people to comment. And, I, as a former FTC policy director, I know the weight of these comments, and your voice will be heard, and it's really essential. And I really applaud NCL for all of its hard work in bringing consumer voices to the FTC.
Thank you so much. Well, thank you, everyone. Thank you, Carl, David, and Sally. Thank you for your time and for your commitment to this issue. NCL is really, committed to this, and we really love this work. But that's all the time we have today. So thank you to all of our participants for joining as well, and for the great engagement in the chat and the Q&A. To learn more about PBMs and to weigh in with the FTC, please go to our website, nclnet.org/PBMs. And thank you for your time today.